Welcome. Alpha blockers may be used to treat hypertension in resistant cases where other drugs such as ACE inhibitors or calcium channel blockers and thiazide diuretics have proven ineffective or not enough. As with the alpha blockers, alpha-2 agonists are rarely used. They are typically only used when all other conventional options have been exhausted. When used, they usually are taken with a diuretic, and maybe some other drugs too. Alpha adrenergic receptors play an important role in the regulation of blood pressure. There are two principal types of alpha receptors, alpha-1 and alpha-2, and both of them participate in circulatory control. Alpha-1 receptors are the classic postsynaptic alpha receptors and are found on vascular smooth muscle. They determine both arteriolar resistance and venous capacitance, and thus ultimately blood pressure. They are also found on the bladder neck muscle and prostatic capsule. This chart is reflective of alpha-1 receptors only. Alpha-1 receptor antagonists in the eyes have no recognized therapeutic applications. Alpha-2 receptors are found both in the brain and in the periphery. In the brainstem, they modulate sympathetic outflow. Their function in the periphery is not yet fully understood, but they may contribute both to control of sympathetic tone and to local and regional blood flow. The lack of understanding of their action in the periphery is why they were not included in this table. Alpha-2 antagonists have no recognized therapeutic applications in humans. But we're going to talk about alpha agonists later. First, we will talk about alpha-1 antagonists. Alpha-1 receptors are predominantly found in smooth muscle, such as the blood vessels or the urinary tract. Stimulation produces contraction, and inhibition causes relaxation. Alpha blockers are highly selective for the alpha-1 receptor, causing vasodilation and a reduction in blood pressure. Alpha-2 antagonists are used for resistant hypertension, benign prostatic hyperplasia, and pheochromocytoma. For pheochromocytoma, it's given with the beta blocker propranolol. One group, represented by prazosin, contains drugs that produce alpha-1 blockade. It's more non-selective. The second group seems to be more selective in their action on the bladder neck muscle and prostatic capsule. There's little difference in efficacy between the alpha blockers for BPH, so these are selected mostly by cost. Hypotension is a significant adverse event with all alpha blockers and can lead to falls, fractures, and head trauma. There are increasing concerns about falls and fractures in BPH patients taking selective alpha blockers. We know that non-selective alpha blockers cause orthostatic hypotension, and we're used to thinking that the prostate selective alpha blockers are much safer. But now these drugs are also linked to an increase in falls, fractures, and head trauma, possibly due to hypotension. There's about one more fall-related hospitalization for every 600 men using a selective alpha blocker, and about one more fracture for every 1,600 men. So help prevent falls. Advise patients on selective or non-selective alpha blockers to rise slowly, especially when first starting therapy. Be careful using alpha blockers with meds that increase fall risk or reduce blood pressure, such as sleeping medications, PDE5 inhibitors such as sildenafil, which is Viagra. Alpha blockade can dilate the blood vessels of the nasal mucosa, producing nasal congestion. And silodocin has selectivity with the alpha-1 receptor that regulates smooth muscle tone in the bladder neck, which they all do, urethra, prostate, and the vas deferens. This selectivity means that silodocin has the highest incidence of abnormal ejaculation among the alpha blockers. So I would probably not prescribe that one. Alpha blockers pose a risk of intraoperative floppy iris syndrome during cataract surgery in current or previous users. This occurs most commonly with tamsulosin. Patients with a history of cataracts or decreased vision should be evaluated for need for cataract surgery before starting an alpha blocker. Advise patients on alpha blockers to tell their ophthalmologist prior to cataract surgery so modifications for surgery can be anticipated. Alpha blockers are not recommended as the first-line antihypertensive agent. Preferred drugs include the calcium channel blockers, ACE inhibitors, thiazide diuretics. Alpha blockers are generally used when other antihypertensive agents have been exhausted. The administration of other antihypertensives have an additive effects. Likewise, co-administration of an alpha blocker with a PDE5 inhibitor may cause symptomatic hypotension in some patients because they're both vasodilators. To prevent the kidney from neutralizing hypotensive actions, alpha blocking agents are usually combined with a diuretic when used in patients with hypertension. Forewarn patients about first dose hypotension. Advise them to sit or lie down if dizziness or lightheadedness occurs on standing. Teach patients to move slowly when changing from supine or sitting position to an upright posture. Urge them to avoid driving and other hazardous activities for 12 to 24 hours after the initial dose. Reinforce taking the initial dose at bedtime to minimize the first dose effect. First dose postural hypotension is often worse with doxazocin. Now we're going to talk about the centrally acting alpha-2 agonists. As with the alpha blockers, alpha-2 agonists are rarely used. They are typically only used when all other conventional options have been exhausted. When used, they are also usually taken alongside a diuretic. Alpha-2 agonists are classified as centrally acting alpha-2 agonists. These receptors are activated in the brainstem, which once activated, open peripheral blood vessels around the body, reducing blood pressure. I only included drugs in this example list that are PO and used for hypertension. Please note that methyldopa is preferred in pregnancy. Side effects of centrally acting alpha-2 receptor agonists include sedation, headache, and fatigue. Also included are dry mouth and dry nasal mucosa. There may be bradycardia because of increased vagal stimulation of the SA node, as well as sympathetic withdrawal. Orthostatic hypotension and impotence are also common. Constipation, nausea, and gastric upset are also associated with the sympatholytic effects of these drugs. Fluid retention and edema is also a problem with chronic therapy. Therefore, concurrent therapy with a diuretic is necessary. Sudden discontinuation of clonidine can lead to rebound hypertension, which results from excessive sympathetic activity. For methyldopa, two side effects, hemolytic anemia and hepatitic necrosis, can be severe. Needless to say, I've never prescribed methyldopa before. Take at least one dose at bedtime to minimize daytime sedation. It's usually prescribed BID. Dry mouth can be significant. Inform patients that discomfort can be reduced by chewing sugarless chewing gum, sucking hard candy, and taking frequent sips of fluids. At high doses, clonidine can cause subjective effects, euphoria, sedation, hallucination, that some individuals find desirable. Taper gradually to reduce rebound symptoms. Because the hypotensive effects of clonidine are not posture dependent, orthostatic hypotension is minimal. Thank you for your time and attention. I hope you have a great day.